Hi, my name is Savannah Egan, and I'll be presenting my periodontal case study. Just a little bit of background information of my patient case selection. My patient was a 62-year-old male. His supragingival deposit score was a 3. His subgingival deposit score was a 3.5. He has stage 3 grade B periodontitis. He has irregular preventative dental care. And he actually commutes from Roseburg. He's a patient that I connected with from my personal office that I work at as a dental assistant and was interested in coming to see me for treatment in Eugene. So he was motivated to drive that far. Some background with his medical history. He was an ASA 2, mostly due to age. He has hypertension. He's taking lisinopril and amlodipine. His most recent exam was summer of 2024, and his most recent full series of radiographs was summer 2024, but he was unsure of his most recent cleaning. Let's dive into his medications. He's taking amlodipine. His therapeutic use was an antihypertensive. The pharmacologic category was a calcium channel blocker. I put that in red with an arrow to it because you'll see one of the oral considerations is gingival hyperplasia later on when I provide some pictures. He's also taking lisinopril. The therapeutic use was an antihypertensive. Its pharmacologic category was an ACE inhibitor. Oral considerations include cough, Stevens-Johnson syndrome, dysplasia, and xerostomia. The initial appointment, when we took assessments, we took his vitals twice because they were elevated, so we ended up referring him to his primary care physician to evaluate his elevated blood pressure despite being on 2 antihypertensive medications. To continue with assessments, we do an EO-IO exam, periodontal charting. We use the microscope, a radiographic assessment, an oral hygiene assessment, a dental exam with the dentist, risk assessment, and treatment plan. His EO-IO exam, he had an angles classification of a bilateral class 1, a 4 millimeter overjet, and a 5 millimeter overbite. 11 and 22 were in crossbite. No midline deviation. He had some localized moderate anterior attrition and some severe attrition on the incisal edge of number 8. He had some normal head and neck findings, some prominent vascularity on the lateral borders of the tongue, and Fordyce granules on the anterior buccal mucosa. So we look over periodontal charting. I have his periodontal chart up to look at too, but I figured I would bring up some clinical assessment markers. He has quite a few furcations. What I really want to point out is he has mobility on his lower mandibular anteriors. 23 was a class 1, and 24, 25, and 26 were all class 2 mobilities. His probing depths, he had 58 probing depths over 3 millimeters at his initial periodontal charting visit and 38 bleeding points at his initial visit. Here's his periodontal chart to review. You can see he has many bleeding points, many deeper pockets, some furcations over here. Next, we do the microscope. He had many spirochetes, gliding rods, spinning rods, white blood cells, epithelial cells, and cocci. It was a very motile slide, so he is a risk factor of a C. This is just a quick explanation of receiving his radiographs from his private office. I wasn't the one to take the full mouth set of radiographs. If I had been the person taking his full mouth set, I would have exposed vertical bite wings to get a better assessment of the alveolar bone level. Here's his full mouth series of x-rays taken summer of 2024, sent by his private office. Here is the same set of x-rays, just with a little bit of evaluation. The green is where a normal bone level should be, and the red is where his bone level rests. Most are within the 15 to 33% horizontal bone loss range. Once you get down to the mandibular anteriors, you can see that there's some pretty extensive bone loss, greater than 33%. Down on the lower left, you can see there's some furcation involvement and a little bit of vertical bone loss. Overall, his radiographic assessment showed generalized moderate horizontal bone loss, localized severe horizontal bone loss in the mandibular anterior area, some localized furcation involvement, and some localized vertical bone loss. We move on to his oral hygiene assessment. He wasn't doing much as far as his home care routine. He reports that he brushes once daily and occasionally uses floss picks, so there was no interproximal cleaning. Here we have some new patient oral images. Maxillary lingual view and mandibular lingual view. Here we are back to gingival hyperplasia. In hindsight, I wish I got a little bit more of a zoomed in picture of this area because he is on calcium channel blockers. He had some gingival hyperplasia in this area. We applied disclosing solution to view the plaque. And you can see a lot of it is that darker purple color, which means it's been there for a while. Here's the maxillary lingual and mandibular lingual view. And I took a few extra to just kind of show the thick band of plaque along the cervical third, the margin of each tooth. So we did an assessment and his plaque-free score was only 26% plaque-free. And so this was a good way to kind of show him with a mirror and motivate him with some home care instructions. So we discussed thoughtful sulcular brushing, interproximal brushes, a rubber tip stimulator, and an end tuft brush to reach kind of posterior areas, furcation areas. I did not introduce the perio aid right away because I find that a lot of people are kind of scared of it when you first introduce it. So we introduced these easier home care instructions to motivate him. You'll see we also dispense Prevenant for caries prevention because with his dental exam he had some active carious lesions. His instructions to use that were to brush with the paste once daily, spit, but do not rinse. We also discussed the importance of adequate water intake because he does take lisinopril, and one of the side effects is xerostomia. Here are our tissue statements. He had generalized slight hyperemia, generalized slight enlargement, localized moderate anterior blunting, generalized moderate recession, and gingival hyperplasia in the mandibular anterior facial. He was a generalized slight edematous consistency. And back to his dental exam and his active carious lesions, he has number 12 has a lingual cusp fracture. The dentist recommended an OL DHR composite, so actually all of his restorations were DHR appropriate. Number 14 had lingual pit caries. Number 19, lingual had recurrent caries. He suggested amalgam to restore this instead. 29 had DO caries. Here's a view of his existing restorations and his proposed restorations. After combining all of those assessments, we did a risk assessment, and his risk assessment is high. Here are his major contributing factors to a high risk assessment: his irregular preventative dental care, medications that cause xerostomia, visible plaque, unusual tooth morphology, so he has a crossbite and some crowding, active caries, and exposed root surfaces. And then we use that risk assessment to create a treatment plan for him. His goal was to achieve routine cleaning, so he just wanted to improve his cleaning schedule and his home care routine. As far as interventions go, we talked about sulcular brushing and interproximal cleaning instructions. We will plan to do non-surgical periodontal therapy by quadrant and apply fluoride varnish and dispense Prevident for caries prevention. The expected outcomes include the patient leaving with plaque and calculus debrided to allow for gingival healing and to maintain his periodontal disease. And he will reschedule with periodontal maintenance appointments. Here's our treatment plan in a sequence, and it shows the number of appointments. So the first appointment, we did a comprehensive oral evaluation. We applied fluoride varnish. We provided oral hygiene instructions. I did a caries risk assessment. I had a plan to start one quadrant of the mouth, and I prescribed Prevident. The dentist prescribed Prevident. Appointment 2 just continues to more periodontal scaling, and the next 2 are also the same, just kind of working on his non-surgical periodontal therapy by quadrant. He did sign a non-surgical periodontal therapy consent form, which addresses any risks associated with therapy, anything involved in therapy. So it just includes supportive therapy like curettage and laser and Arrestin, things like that. It discusses how each patient responds differently to treatment, in that post-operatively, the patient also has some responsibility in their periodontal condition in their home care. It discusses pain, soreness, and sensitivity after therapy, bleeding, recession, the risk of broken instruments during therapy, increased mobility of the teeth during the healing period after non-surgical periodontal therapy, noise and water spray during treatment, and post-treatment complications. So the patient came back on March 11th, and we started with the lower left quadrant. He didn't have any concerns this appointment. He did report seeing his private dentist for some restorative treatment. He still had the same kind of home care routine. He was brushing once daily and sometimes using floss picks. As far as adjustments go, we kind of just used some positive reinforcement. So I reinforced interproximal brushes, the rubber tip stimulator along the marginal gum line, and thoughtful sulcular brushing. His vitals were a little bit elevated this time. Again, and it sounded like he was in contact with his primary care physician. Once we got started on treatment, we did a lower left inferior alveolar nerve block and a lung buccal injection for anesthesia. We used the ultrasonic and then hand scaled to completion. There was generalized moderate bleeding, generalized severe marginal and interproximal soft deposit, generalized moderate supragingival hard deposit, generalized moderate to heavy interproximal subgingival hard deposit, and some localized moderate marginal subgingival hard deposit. At this appointment, we did place Arrestin on 18 distal and 19 distal. So those lower left molars, he has a little bit of a hard time reaching and cleaning there, and he had some deeper pockets there. His next appointment was on March 31st. We treated the upper right quadrant. He had no concerns, and he just reported little soreness after the last visit for non-surgical periodontal therapy. He reported brushing once daily and flossing sometimes, and that he hadn't been using the interproximal brushes given to him at his last appointment. I was really hoping that he would. He is a really busy person, working a lot, moving, and so I was just kind of hopeful that maybe the timing was just kind of holding him back from working on his home care routine, because he did seem motivated. So we used some positive reinforcement and just really stressed interproximal cleaning, specifically with the Tepe interproximal brushes, and also sulcular brushing. His blood pressure, again, was a little bit elevated. It was 126/96, so we took it again. It was 120/90. When we got started with treatment, we did a right PSA and a right AMSA. We used the ultrasonic scaler and hand scaled to completion. Bleeding was, again, generalized moderate. He had generalized severe interproximal hard deposit and generalized moderate marginal and interproximal soft deposit. His next appointment, we were able to get 2 quadrants done. He came back on April 7th. He had no concerns this time. For home care compliance, I noted that tissues had improved. He was starting to use the interproximal brushes more, and actually told me almost daily. So we just reinforced that technique, and we discussed some sulcular brushing along with that. And then I did another tell, show, do home care technique for the end tuft brush to reach those distal of those molars where we saw some deeper pocketing. At this appointment, we did a left PSA and a left AMSA to anesthetize the upper left quadrant, and we did a right IA to anesthetize the lower right quadrant. We used the ultrasonic scaler and hand scaled both quadrants to completion. Bleeding was generalized moderate. Deposit was generalized severe subgingival interproximal hard deposit and generalized slight marginal and interproximal soft deposit. So the soft deposit went down and the tissues were starting to improve, just with partial non-surgical periodontal therapy and some improved home care. We placed a topical fluoride varnish for caries prevention across the entire dentition. And actually, when we scaled, we came across the root surface of number 19 and found some caries that needs to be evaluated by his private dentist or by the LCC dentist at his reevaluation appointment. And he came back for his 4-week reevaluation on May 9th. At the 4-week reevaluation, we do a tissue evaluation with an oral hygiene assessment. We do a microscope assessment. periodontal charting, a new treatment plan, laser pocket disinfection, and then we do retreatment and full mouth scaling. And throughout this entire process, we're doing some continuous analysis. So the patient sits down in the chair, and we usually go straight to look at their tissues, just to see what's changed since we saw them 4 weeks ago. And we identify causative factors for any remaining areas of inflammation. And I think the main factor was just some generalized soft deposit. So we still had soft deposit that was generalized, just not in the amount that it was before, though. He did have a few remaining deposits, number 29 distal, number 25 mesial, and number 14 mesial. And he had some slight supragingival hard deposit on the maxillary left lingual premolars in the mandibular lingual anterior. There was a decrease in the mandibular anterior gingival hyperplasia. And so overall, I was finding that positive reinforcement is really what was getting him to improve his home care routine. And so we use pretty much the same home care tools as I introduced in the beginning, but it was just reinforcing those at every visit and being positive about it. And his plaque-free score went from 26% to 41% plaque-free. Here are some reevaluation photos. You can see the tissues have improved quite a bit. Here's the mandibular facial anterior, and you can kind of see that reduction in gingival hyperplasia. I applied disclosing solution at the reevaluation, and you can see that there is still generalized biofilm, but this time it's more of that pink color, so it's newer biofilm instead of that dark purple color that you see in his original pictures. And here's some comparisons. So the mandibular facial anterior on the left is at his initial visit, and you can see that dark purple biofilm hanging out at the marginal gingiva. And on the right is at his reevaluation visit with disclosing solution. You can see there's a lot less biofilm, and it's the pink newer biofilm. So he's at least removing it. Here's another good comparison from the initial appointment to the reevaluation appointment. And I did periodontal charting again. I think that the most significant finding in his clinical assessment markers were the fact that his class 2 mobility actually reduced to class 1 mobility. And that was only 4 weeks after non-surgical periodontal therapy. He had 58 probing depths above 3 millimeters at his initial visit, and that went down to only 4 probing depths above 3 millimeters at the reevaluation visit. And his bleeding points went from 38 down to only 6 bleeding points. Here's his periodontal chart at his reevaluation. His pocket depth comparison. We did perform another microscope evaluation, and his risk factor went from a risk factor of C to a risk factor of B, so that improved. His risk assessment, he was still high with his risk assessment, but there are less contributing factors this time. So just the medications that cause xerostomia, unusual tooth morphology, active caries, and exposed root surfaces. And the big one that put him into the high category was his active carious lesions, and he plans to see his private dentist for those. Our goals this time were to just continue with a consistent 3-month periodontal maintenance interval and to increase his brushing frequency, because that's something that he hadn't increased at home. He went from not flossing or using any interproximal cleaning to now using them, but he did not increase his frequency of brushing to twice a day. Our interventions were positive reinforcement for sulcular brushing and interproximal cleaning. We're going to do a 4-week reevaluation this day, and then a plan of 3-month periodontal maintenance intervals. At this appointment, we also did place fluoride varnish again for caries prevention. Here's his planned appointments, the 4 to 6 week reevaluation, and then his second is periodontal maintenance. We did do a full mouth laser pocket disinfection. We did full mouth scaling. We did not need anesthesia at this visit with the tissues healed. We did a full mouth pre-polish for soft biofilm removal. We used the ultrasonic scaler and hand scaled to completion. He had generalized slight bleeding and some localized slight to moderate subgingival hard deposit and just some generalized soft deposit. The next treatment phase is 3-month periodontal maintenance, and actually he's going to come see me at his private office where I work to perform his periodontal maintenance. And he will be due for vertical bite wings September 5th of 2025. And like I said before, he will do restorative treatment at his private dentist's office. And just to kind of look at the case study overall, some questions I asked myself were, did the treatment meet all the needs of the patient? I would say yes. Was the patient education adequate enough to motivate the patient to comply with home care recommendations and to arrest the patient's periodontal condition? The home care and periodontal status have slightly improved, but the frequency and quality of home care could still improve. The patient did complete NSPT and reevaluation, so I would say he's motivated to keep coming in for treatment and to come in for periodontal maintenance. Was the quality of treatment optimum? I believe so. And that is my periodontal case study. Thanks for listening.